You're listening to Blood Bank Guy Essentials, episode 21. With us in the blood bank, often it's easy to say, oh, well, they just gave him too much. What's the big deal? It is a big deal.
It's a massive deal. And yeah, not just recent FDA data. You can look at these trends. Over the last 5 years, taco and trolley are the top two causes of transfusion-mediated death in the U.S. And that should be kind of a startling soundbite.
Hi, everyone. Welcome back to the Blood Bank Guy Essentials podcast. My name is Joe Chaffin, and I am your host. My guest for today is Dr. Garrett Booth from Vanderbilt University, and I'm very excited to share this podcast with you. Before we get started, though, I wanted to just share a milestone that we just passed. When I started this podcast back in April of 2016, I really just kind of hoped that people in my family might listen to it, to tell you the truth. As it turns out, they don't. My family doesn't listen to this at all, but you guys do. So I'm incredibly honored that you do. And we just passed a big milestone, over 20,000 downloads of the Blood Bank Guy Essentials podcast in countries all around the world. And I am just so very grateful for you for listening to this, and the feedback that you've given me has just been wonderful, and I appreciate it so much. There are 3 more episodes for 2016 that we'll be doing after this episode, and then we'll rewind and reboot for 2017. If you have not checked out the most recent podcast, episode 020, Dr. Jeff McCullough talking about pathogen inactivation, I really highly recommend it. It's a great interview, and Dr. McCullough is so incredibly knowledgeable. So Dr. Garrett Booth today is from Vanderbilt University, as I mentioned. Garrett is a passionate guy. He's a funny guy, and he's incredibly smart. So I really think you're going to enjoy this interview where we're talking about transfusion-associated circulatory overload, and I'm excited to share his insights with you. So no more waiting. Here's my interview with Dr. Garrett Booth. All right, everyone, welcome to Blood Bank Guy Essentials episode 021. As promised, I am happy to welcome my guest, Dr. Garrett Booth from Vanderbilt University, to the podcast. Garrett, welcome.
Thank you for having me.
It is an honor to have you here, my friend. I want to tell everyone a little bit about you before we get started, because you're doing some really great stuff, and it's very exciting, and I'm super glad to have you as my guest. Everyone, Garrett is an assistant professor in the Department of Pathology, Microbiology, and Immunology at Vanderbilt University. He serves there as the associate medical director for the Vanderbilt Blood Bank, as well as the medical director for the apheresis service. Garrett did his undergrad training at UCLA, went to University of Arizona College of Medicine, returned to UCLA for his clinical pathology fellowship, and did his blood bank fellowship at the National Institutes of Health. If you look around a little bit and do PubMed searches, you would certainly see that Garrett has been involved both as senior author and primary author and all kinds of authors on numerous articles in peer-reviewed journals, and all that is awesome and great. Those of you that listen to this podcast know that I have a very soft spot for people that are passionate about teaching, and Garrett definitely qualifies with that. Garrett has been involved in a project that I've known about for some time, and I'm sure many of you have as well. But it's very exciting, and he's done a lot of work with collaborators on a project called pathquestions.com, which is now involved with the website transfusionnews.com. And Garrett, I've talked too long. I really want to throw it to you, and why don't you take as much time as you want and tell us a little bit about that project, and tell us a little bit about where you've been with it and where you're going with it.
Yeah. Well, first, thanks for the introduction.
Sure.
I couldn't do any of the work with pathquestions.com or transfusionnews.com without the amazing support of my collaborators. Specifically, I'd like to reference all of them. Ron Jacobs, who's faculty at Wash U in St. Louis, at Barnes Jewish Hospital and St. Louis Children's. Bill Lane at Harvard Medical School and Brigham and Women's Hospital. Without them, none of that would have been possible. And they brought me on board to help serve as an editor. And we have recently added a number of outstanding collaborators, both domestically and internationally. We have Eric Gary, who's at faculty at Johns Hopkins Medical Center, Lorraine Blagg, who is at SBB at Johns Hopkins Hospital, and Diarmuid O'Donnell, who is the director of the Irish Unrelated Bone Marrow Registry and the National Tissue Typing Laboratory as part of the Irish Blood Transfusion Service. And to be honest, the way in which this got started is just pure coincidence. I had been collecting and amassing questions based on articles that I've been reading or books that I've been reading for years. And I went to a medical conference and I was talking with another junior faculty member who had said something like, man, there should be an easier way to try and help educate and train people. And I was talking about the total number of questions that I had in my own personal question bank that I'd started using for the SBB program at NIH, and then ultimately for my co-fellows, and then starting to distribute them to the residents at Vanderbilt. And she said, you know, there are these two other guys that are doing something pretty similar. And I contacted Ron and Bill by email, and we started an online collaboration that when we initially started, 5 or 6 years ago, I think none of us knew what we were really getting into. And our expectations or how we define success was, could we get 20 people to go online and look at our questions? And then it was 200 and 2,000. And now there's so many users, both domestically and internationally, that when you look at it from a Google Analytics perspective, it just boggles my mind. And I'm sure that you went through that as well. I mean, your website, we owe a tremendous debt and a lot of gratitude to you, to your outreach. And so we're just building on that legacy and trying to expand in certain avenues to provide the entire transfusion community, which I would include medical technologists, nurses, physicians, pathologists, and non-pathologists, with an avenue to get up to date, accurate, peer-reviewed questions, videos, and content review, which is no small task. And I, as I said, owe a lot of credit to my collaborators.
No. So tell everyone, Garrett, specifically how they can either sign up or visit the site and tell us about costs and things like that.
Yeah, absolutely. The easiest thing is to make sure we just reiterate that it is completely and totally free.
Nice.
Transfusionnews.com. You just go to the website, you sign up. It'll ask you a series of questions. We collect your email. We don't spam you ever. And what we do is we just send you questions to your email account. You get 3 questions per week, Monday, Wednesday, Friday. They are designed to be quote unquote easy, moderate, and hard as the week progresses. And it works on any platform. So whether you have an Apple or a PC, an iPhone, or an Android, it will work on anything. Our average question, if you look at how long people are on the site, doing the questions in English-speaking countries, is around 2 to 3 minutes. Okay. And for non-English-speaking countries, a little bit longer, and that may just be some kind of translation issues, which we're hoping that we can entice some additional people and professional organizations to help start to translate them to non-English speaking languages. But it's totally free and it works on any platform. And what we've been trying to do for years now is to remove the barriers towards education. And I think that one of the most important reasons why I got involved in this is, I love going to professional medical meetings, but they're pretty expensive, and maintaining the dues and the travel and the hotel right off the bat means that a number of very well qualified or very eager individuals simply can't go. It's a financial hardship that a lot of hospitals can't take, particularly in today's fiscal environment. And so, doing things like these podcasts and working on these types of websites is in an effort to continue to give accurate, up-to-date information that's peer-reviewed without a barrier, so that people can feel empowered about what they're doing in their daily practice, or if they're a trainee, what material they're learning, without having to shell out hundreds, if not thousands of dollars. And I take nothing away from those meetings. They're great, and I participate in them. But our goal is to try and expand that scope.
Understand. Well, you guys are doing a great job. I've been in communication with you guys in the past, with all three of you guys actually, and have expressed to you guys before that I love what you're doing, and I hope that everyone listening just so transfusionnews.com, is that the easiest way to get there now? Okay. Got it. Okay. So Garrett, with that as an intro, and thank you for sharing all that with us, I want to get into our topic for today, which is something that I think that people struggle with. It's a fairly common scenario, fairly common situation that people are really, I think in many cases, especially when you're learning, have kind of difficulty figuring out. So without giving away what we're talking about today, well, obviously if people are listening to the podcast, they probably already know. Let's do a case and let's talk a little bit about this and see where we can go. So you ready?
Absolutely.
All right, let's rock and roll. Okay, so here's a case. We have a 57-year-old male who's on chronic warfarin therapy because he has a history of atrial fibrillation. He presents to the emergency department after he's fallen off a ladder onto his driveway. Not a good thing. His speech is slurred. He appears sluggish. They think he hit his head, obviously. His INR is elevated. It's 3.7. And in the emergency room, they decide that they need to reverse this anticoagulation right away. So they slam him with 8 units of FFP over the next four or so hours. The following morning, they check his INR, and my gosh, it's still back up there. And so they order another 8 units. When they're trying to give that, the third unit that they're trying to give of that second set of 8, he all of a sudden starts coughing, and he says, "Wow, I can't breathe. I can't catch my breath." They look at his blood pressure. It's elevated. It's 150/88, and his oxygen saturation is 88% on room air. So this, we're obviously deliberately kind of stopping there. But Garrett, when you hear a story like this, when we've got someone who's getting transfused and suddenly has trouble breathing, what are the kind of things that we should think about?
Yeah, this is a great clinical scenario, in part because, one, it's not uncommon, and two, it's vague enough that it incorporates any number of suspected transfusion reaction possibilities. And I really like that term, suspected transfusion reactions. And in one of your prior podcasts with Dr. Mark Fung, he really reiterated that let's stick with that term. And I agree, in part because otherwise clinicians and laboratorians will jump to the blood product as, well, it must be that because it happened while the blood product was going into the patient. For example, in this scenario, the 11th total unit, and therefore it must have been the FFP, right?
Right.
Well, I think when you look at patients that are receiving blood products that have a pulmonary type reaction, you can kind of break it down into 2 general camps. One could be, is this a primary pulmonary transfusion reaction or a secondary pulmonary transfusion reaction, or unrelated, or a combination? Primary transfusion reactions would be things like transfusion-associated cardiopulmonary overload, transfusion-related acute lung injury, and then kind of the redheaded stepchild, transfusion-associated dyspnea. There's always secondary cases of transfusion reactions that can have pulmonary symptoms as well. If you have a severe allergic reaction or an anaphylactic reaction where you have angioedema and your airway is narrowing, well, obviously that's going to compromise your cardiopulmonary system. If you have a transfusion-transmitted bacterial infection and you go from otherwise normal to now being septic, that can have respiratory compromise. And hemolytic transfusion reactions, if you start to hemolyze all of the red blood cells and therefore decrease the oxygen carrying capacity of the blood in your patient, then you're going to have some degree of respiratory compromise. But I think the other thing to keep in mind, particularly in this 57-year-old patient, this clinical vignette, is that, look, the patient has multiple comorbid medical conditions, right? They're on a medication that's a blood thinner because they have an underlying cardiac-related disease, in this case, AFib. And they come in and they have some degree of altered mental status, and they have an elevated INR, and so they're trying to rapidly reverse it. We also have to keep in mind that this is probably not the only fluid going into this patient. So they'll start venous access, or they'll have a central line in place, and the patient's going to be receiving multiple products, if, not just blood products, as I said, medications, fluids, potentially antimicrobials as well, depending on the clinical scenario. And so I think when you're in the lab and you get this phone call, it's important to keep all of these things in mind. And I think that the most important thing, if you don't remember anything from this talk, is to always stop the transfusion and work backward to disprove the worst case scenario. So, when I mentioned secondary causes, things like an acute hemolytic transfusion reaction, thankfully is extraordinarily rare because all of us within the transfusion community put forth so many different safeguards to ensure the right product goes to the right patient at the right time for the right indication. But mistakes are made. Yeah. And so, when you get that post-transfusion sample, that purple top tube coming back to the lab, and you spin it down, checking for visual hemolysis is critical. Even though you may have no inclination that if there's a hemolytic reaction or your pretest probability is very low, that is absolutely essential to ensure that there wasn't a mistake, because you, from the laboratory perspective, may have issued the right product to the right patient, but a different healthcare professional may have walked into the wrong room and administered the product. And so that may be the first instance where that's being picked up or identified. There's also the possibility that you send the right product to the right patient at the right time, but there was a pre-analytic error, meaning that a specimen was sent for that patient, but there was a wrong blood and tube. And this is, again, extraordinarily rare, but just reiterates the fact that you should always be checking the post-transfusion sample for any degree of visual hemolysis and looking at a direct antiglobulin test or a direct Coombs to see if there's any degree of immunoglobulin coating the surface of the red blood cell, which may be a tip-off for an ABO-related hemolytic transfusion reaction. So with that being said, if you start to rule out some of the big nasties, right, the acute hemolytic transfusion reaction, and you're delving into the clinical case and you're speaking with the healthcare provider or you're at the bedside, I think it's pretty obvious when people are having a severe allergic reaction and they have airway compromise, but not always. These can be subtle findings. And many of the supportive therapy that's done immediately thereafter can be similar. For example, stopping the transfusion, keeping venous access open, make sure there's a protected airway. Because even in situations of transfusion-associated circulatory overload, intubation is not completely uncommon. And there is a tremendous amount of increased morbidity and mortality risk that comes with these things. Obviously, for bacterial infection, the post-transfusion workup can be a little bit more complicated and maybe a little bit more labor-intensive. You may have the ability to do a gram stain very rapidly and hopefully get pretty good turnaround time out of that. And then sending the product ultimately for culture. But the pretest probability for gram stains, if you look at clinical trials or published data related to things like the Passport trial, the sensitivity and specificity of a gram stain of a unit of blood is not the same thing if you look at gram stains for other medical procedures, like swabbing a wound site. So it's pretty low, but if it's there, then it obviously helps you with your diagnosis. Right. But the big, to get back to this case, the things that really stand out are, if you believe this is related to blood product or blood product administration, and you say, well, this is not this patient's underlying disease, then I think the two biggest things that you're trying to differentiate in the respiratory setting are transfusion-associated circulatory overload versus transfusion-related acute lung injury.
Okay, Garrett. So that's a great look at that case, and I think it's really important the approach that you've taken there. Hopefully everyone knows that, since you probably saw the name on this particular episode of the podcast, we are actually focusing today primarily on transfusion-associated circulatory overload, or the horrible acronym TACO. Anyway, so what we'd like to do is just kind of give you not just an overview, but we want to delve into the specifics of TACO, and we want to take you through 5 essential tips. Garrett and I have worked together to come up with 5 essential tips on TACO. So the first one, Garrett, kind of goes to what you've already described, and that's that TACO is one of several respiratory-related transfusion reactions. One thing before I throw it back to you is I want to make sure that everyone understands something really important that Garrett said just a moment a moment ago, which is that, yes, it's really easy to focus on this must be due to the transfusion. But as Garrett was just telling you, there's a lot of not just transfusion possibilities, but there's a lot of other possibilities as well. One thing I always say to residents is just because someone's getting transfused doesn't mean that they can't have a pulmonary embolism or an MI or something else aside from the transfusion. So all that is important to keep in mind. So Garrett, with our first tip, taco is one of several respiratory related transfusion reactions. You've already kind of started down this pathway a little bit, but can you just kind of give us a general description of those? You mentioned circulatory overload, transfusion related acute lung injury, and the stepchild, the transfusion associated dyspnea. Can you just give us kind of a high level overview of how those differ?
Yeah, absolutely. So taco, trolley, and transfusion-associated dyspnea have a tremendous amount of overlap. If you were trying to draw a Venn diagram, you'd see that these circles are very much interlocking. For transfusion-associated circulatory overload and for trolley, there's always a temporal component. As I mentioned, this typically is a respiratory-related compromised state in the recipient of the blood product within 4 to 6 hours of transfusion. This can present in any number of ways, but most commonly, these are people that become short of breath. So they demonstrate some degree of dyspnea. This will also result in their oxygen saturation decreasing. So whether this is measured by a pulse oximeter, that little thing that's wrapped around their finger, or if they have a more invasive test, which would be a blood gas. And you can measure the degree of oxygen carrying capacity in any number of ways, but the end result is that the patient is feeling short of breath. So you've got a temporal component, and then you have a clinical component. And remember that all of these respiratory-related illnesses are a clinical diagnosis. There are a number of additional tests or laboratory evaluation tips that can go into trying to differentiate these. People often jump to chest x-ray and they'll say, well, what does the chest x-ray show post-transfusion? And for trolley, the pathognomonic thing that comes up over and over that we teach trainees is to look for new onset bilateral pulmonary infiltrates. That's just a fancy way of saying whiteout on both sides of the lung. You can have a certain degree of pulmonary infiltrates in taco as well. There are other subtle findings, like you may see a widening of the cardiac silhouette. But in the end, the differentiating factor is volume, right? In the setting of trolley, most patients, when you look at their blood pressure following a suspected transfusion reaction, will have a hypotensive reaction, meaning that their blood pressure goes down. Contrast that with taco or volume overload, and the blood pressure is going up. There are other subtle findings that you could see both on physical exam that will help to differentiate them. So if you think about taco as simply volume overload, then you may be able to, at the bedside, notice a certain amount of jugular venous distension. So if you're looking at their neck, you may actually start to see the pulse as it backs up and can actually extend all the way to the mandible. That is something you traditionally do not see in trolley. If you're listening for lung sounds, this is going to be very, very difficult, and it's not generally an accepted differentiating criteria between trolley, taco, or transfusion-associated dyspnea. But then you can also inquire about whether or not there are certain laboratory tests done. A lot of people will try and use the BNP or brain natriuretic protein or peptide. There are a number of different laboratory ways in which you can measure BNP. You can measure just BNP, or depending on where you practice, you may actually measure the N-terminus BNP. Either way, the result is BNP is a hormone that is secreted by cardiac tissue when it's distressed. Right? So you stretch those cardiac myocytes and outpours this hormone. And so if you have expanded the intravascular volume and you've stretched those myocytes, they may cause a leak of BNP into the peripheral circulation, which you can measure. But you have to take all this with a giant grain of salt, right? There are patients that can have trolley that can also have underlying cardiac disease, and therefore their BNP may be already elevated. So what I try and tell our residents is that a single laboratory test can be useful, but it's not don't hang your hat on it, so to speak.
So
because
important.
many of the patients, including the clinical scenario that you put forth at the beginning of the podcast, demonstrate a patient with underlying cardiac disease, right? They have AFib, and that's the reason why they're on an anticoagulant and got all these blood products to begin with. Well, if you have some degree of cardiac stress to begin with, which many of the people that are getting blood products may have, a single value may not be an absolute requirement. Many of the hemovigilance programs will tell you to order a BNP, and I don't discourage that overall. But I don't think you can look at it and say, oh, look, here's the number. And part of this is because BNP ranges will also change. What we consider normal will vary based on the patient age. So the older you are, your cutoff will change it. And then obviously, as you alluded to, if you have underlying comorbid medical conditions like cardiac disease, which is ubiquitous in the United States, well, these people may have elevated BNPs to begin with. And so how you, from a laboratory perspective, differentiate these things is often very, very difficult.
So Garrett, we'll get to that a little bit more. The taco versus Trally coming up in the third tip actually, but let's pull back for just a second and talk. So you've given us a great look at transfusion associated circulatory overload, which, as you said, is too much volume. You've talked a little bit about Trally, and I think Trally itself is probably a topic for another podcast because there's a whole lot of pathophysiologic details there that are more than we have time to cover. But would it be fair to say that I think Mark Fung may have said this, that taco is like water going over a dam, too much water overloading the dam, but Trally is like the holes being punched in the dam and the water cruising through. Is that a fair way?
Analogy. Absolutely.
Yeah. Okay. So what about transfusion associated dyspnea? Just thumbnail that for us, because I think that's one that when people look at the NHSN criteria from the CDC and they see TAD there and they're like, I don't know what the heck that is. What do you think about that?
What do I think about? Well, first, it's a necessary evil, right? Because not every patient reads the medical textbooks and gives you a clear-cut case in terms of their diagnosis. But broadly speaking, transfusion-associated dyspnea, from a hemovigilance perspective, are generally patients that have a mild respiratory distress in the setting of transfusion, which doesn't line up perfectly with transfusion-related acute lung injury, meaning that you can't find any of these implicated HLA antibodies or antigen in that setting, or you're looking for a certain amount of overload. You're looking at chest X-ray, you're looking at the BNP, you're looking at the overall fluid status, the net volume in and the net volume out, and you say, geez, I don't know, they on par, they don't seem too bad. Transfusion-associated dyspnea is kind of you can't argue that they had respiratory distress, but you can't prove it was overt overload or that it was Trally,
right.
And therefore we kind of have this wastebasket diagnosis of, well, it's probably transfusion-associated dyspnea.
I'm so glad you said that.
I'm not a fan of it, but it exists. So yes,
I'm right there with you. I am on record as calling it a wastebasket diagnosis. So I'm glad you said that, so I didn't have to say it. So, all right, so that's tip number one. The taco is one of several respiratory-related transfusion reactions, and everyone, Garrett has talked about transfusion-associated circulatory overload, as well as transfusion-related acute lung injury and transfusion-associated dyspnea. And we're going to get more into the details. Don't worry of at least of taco and Trally, and particularly of taco. But let's go to tip number two. And Garrett, tip number two is that taco appears to be wildly underdiagnosed. How the heck do we know that taco is so wildly underdiagnosed?
Well, credit to the number of people that have studied this, that have come before us, and also the people that help run and maintain these hemovigilance programs. I 100% agree with you that transfusion-associated circulatory overload is massively underdiagnosed. If you take a step back, the real obvious thing is to look at when you look at passive surveillance systems. So if you're in the United States, things like the CDC hemovigilance, which is a program where we as healthcare professionals can adjudicate or make an ultimate determination of, well, was this overload or not, versus active surveillance. So people on the front lines are watching each blood product as it goes out the door, and they're looking at the vital signs for the recipient, either in real time or immediately retrospective of the transfusion. And you will find over and over and over, both in the U.S. and outside the United States, that active surveillance highlights that this is just completely and totally missed. The reasons why it is missed can be highly variable. You know, if you were really into conspiracy theories, you might think, well, people just don't trust the lab, or people may look at it and say, you know, this is a clinical diagnosis. I know how to manage my patient. I don't need the lab's help. I can check the INO status myself, and the intervention is simple. I think they're volume overloaded, so I'm going to give them a little bit of a diuretic. Most commonly would be a loop diuretic like furosemide, or 40 milligrams of furosemide right off the bat. The patient diuresis, they pee out additional fluid, and their breathing returns to baseline. And you say, no harm, no foul. Well, yes and no. I mean, we have a medical, legal, and ethical obligation to report these types of reactions. But what it also does is it kind of undermines the system, in that we don't know if someone's having volume overload unless it's reported to us. I don't think any hospital, even those with the hemovigilance officer, has the bandwidth to record the vital signs of every single recipient at their institution. And as a result, you see these massive discrepancies in published literature as it relates to passive surveillance versus active surveillance. And if you look at Medicare data in the United States, it'll tell you that the incidence of things like transfusion-associated circulatory overload is less than 0.01% of all transfusions. They looked at 2 million plus transfusions, and they said, wow, this is as rare as hen's teeth. But then you look at things like the REDS-3 trial, which looked at a number of academic medical centers in the United States, and will demonstrate that, wow, these results are significantly higher than what is being reported through the Medicare system. Yep. And, so I think it's important that when you're looking at the literature, that you jump to the methods section and immediately look to see whether or not this was active or passive surveillance. Yeah. So I think that is essential for helping to understand the pathophysiology, because you might say, well, is this common or uncommon? Overall, people have kind of settled in at this happens about 1% of the time, which would put it around the same rate as a simple urticarial reaction or simple allergic reaction, as well as the 1% of suspected transfusion reactions for things like febrile non-hemolytic transfusion reaction. But the other thing to keep in mind is that, we know a lot about who's at risk. So I don't know if you want to jump into why is it underdiagnosed, in part because it may be that people aren't paying close attention to who should we be looking out for as potential victims of volume overload.
So I think we'll get into that a little bit when we do the fifth tip on the prevention. But that's really important. I want to interject one thing that sure. My personal experience. I'm in full agreement with everything you just said. My personal experience has been that I'm not sure that clinicians and sometimes blood bankers, I'm not sure we give transfusion-associated circulatory overload the import that it deserves. I mean, when you look at the FDA data as you have said, a passive hemovigilance system, you'll see that a third of the deaths in fiscal year 2015 were from TACO. A third of the deaths. I mean, right there, almost neck and neck with Trally. And when you look at the UK data, where obviously things are active hemovigilance, I just checked this right before we got on the podcast. It is the number one killer in the United Kingdom. And that's, I mean, I think it's, like I said, with clinicians often and with us in the blood bank often, it's easy to say, oh, well, they just gave them too much. What's the big deal? It is a big deal.
It's a massive deal. And not just recent FDA data. You can look at these trends. Over the last 5 years, TACO and Trally are the top two causes of transfusion-mediated death in the U.S., period. And that should be kind of a startling soundbite. But I will say, again, that we don't know what's not reported to us. Right. And so oftentimes, if someone doesn't have increased morbidity, it doesn't change the length of stay, or it doesn't put them in the ICU, and certainly if it doesn't kill them, that these things just go underreported because people will attempt to manage them on the floor without notifying the blood bank. And that's a huge disservice to the patient and the lab because, as we mentioned at the beginning of the podcast, there are critically important things that we want to rule out, whether it's acute hemolytic transfusion reaction or a septic type reaction, which if we aren't notified, it may be too late once we are told, and we want to always work towards avoiding that.
Yep, you bet. Well, so I think that I think we've covered tip number 2, which is that TACO is wildly underdiagnosed. So just to review, TACO is one of several TACO is one of several respiratory-related transfusion reactions. That's tip 1. Tip 2 is that TACO is wildly underdiagnosed, and I want to get to tip 3 because I think this is you've alluded to this already, and we started to get into it a little bit, but let's hit it a little harder. And tip number 3 is that TACO versus TRALI is a constant dilemma. When someone has a respiratory type reaction during transfusion, we find ourselves, and somebody actually tells us about it, that's important, but when we hear about it, we find ourselves trying to distinguish between those two very often. And you've already started down the road of giving us some tips on that, but why don't you go into a little more depth on, and just functionally speaking, you're working at Vanderbilt. You get someone who has a respiratory type transfusion reaction, and it comes down for you to trying to distinguish between TACO and TRALI. How do you try to do it?
First and foremost is always go back to your basics and make sure that the patient's okay. So even if it means to ask the question or at the bedside, go back to your ABCs, airway, breathing, and circulation. Once those 3 things have been established, then you can delve into more detail. So if you take a step back and say, okay, look, this patient is stable right now, whether it's on the floor or in the unit, the important thing is to start to differentiate TACO versus TRALI is to understand a little bit of the pathophysiology and the risk factors that go into these things. Mm-hmm. When you look at volume overload, the obvious thing is who's at risk for this are really the extremities of life. So if you're an elderly patient, which depending on the publication you read, they may qualify that as over 60. If you look at the Medicare data, it would be over 85. Mm-hmm. Or at the really low end, people that are under 3 years of life. Yeah. These are patients by and large that their ticker just is not as functional as a healthy adult. And therefore, you and I can tolerate standard transfusion, no problem. The default volume of the red cell unit's around 350 mLs. Mm-hmm. Platelets, depending if it's a pooled product or an apheresis product, can vary, 2 to 400. Sometimes if it's a jumbo bag, can be a little bit larger. Plasma also around 200 to 250 ml. Cryo, you generally speaking don't see TACO. So if someone called me and they said, hey, Garrett, we have the suspicion of transfusion-associated circulatory overload. We gave this patient 1 unit of cryo. I would say, well, that, my pretest probability would go way down simply because the default volume of cryo is so small. That being said, both TRALI and TACO have been reported on all blood products. Right. So you have to keep that in mind. So just knowing what the product is doesn't help you to differentiate them. Mm-hmm. Back to some of the risk factors, though, the extremities of life, you got to think about who's at risk. People that obviously have pre-existing cardiac or renal-related dysfunction, so they're not able to move blood efficiently or not able to filter blood efficiently, meaning that their pipe and valve system just stinks. Yeah. Well, if your pipe and valve system is suboptimal, well, then you're going to be much more susceptible to overloading it, or as you mentioned, all that excess water going over the dam. Right. TRALI can affect anyone. So whether you have cardiac disease or pulmonary disease, if you look at some of the hemovigilance guidelines, they'll tell you that you can't have a diagnosis of TRALI if you have pre-existing pulmonary disease. I'm not 100% sure I completely agree with that, especially if you think about the proposed mechanisms, which, people will talk about, well, there's a combination of HLA antibodies and the cognate HLA antigen. You're transfusing it. The first and largest capillary bed that blood is ending up in is in the pulmonary space, and you get these antibodies that get stuck within the alveolar space, which will cause a leakage of fluid into the lung space and therefore disrupt the ability to breathe. And then you get that, you get that clinical picture of, well, look, this patient is having respiratory distress. Well, I think just because you have a underlying cardiac or pulmonary disease doesn't preclude you from having that, in my opinion. And, some people have alluded to in publications things like a touch of trolley. Maybe it doesn't have to have bilateral pulmonary infiltrates, but you get some degree or moderate amount of that. So you got some risk factors that will help to favor the diagnosis of TACO. So, knowing who the recipients of blood products are, it becomes critically important. Also, keep in mind that United States and globally has done a tremendous amount of work to try and reduce the incidence of trolley. It has not gone away, but by excluding donors or working to exclude female donors with a history of pregnancy, we're trying to reduce the potential burden of these HLA antibodies in the blood supply. But it doesn't always work. So again, to help to differentiate them, you're going to want to know, well, who is your blood donor and whether or not this donor has ever been implicated in a prior suspected transfusion reaction, or is the donor a woman and does this patient or the donor have a history of pregnancy? And I think that's important to bring out because not all blood types are equally represented. And so if you look at patients that are receiving plasma, say, from an AB donor, well, we don't have an exclusively male AB plasma donor population in the United States. It simply doesn't exist with less than 1% of the population being blood group AB. So you're still going to get female donors, and that's just a byproduct of we can't rely on half the population to supply the entirety of the blood supply.
Right. And that's true, Garrett. I would interject that though as of a few days ago, the beginning of October, if a female is going to be a plasma or platelet donor, and plasma donor for sure in that AB group, they do have to be tested now for HLA antibodies if they've been pregnant.
Yeah, and again, another outstanding step in trying to reduce the risk, but it's not a guarantee.
You bet.
The other thing is, again, take a step back. You get this phone call and they're trying to differentiate TACO versus trolley. TACO is by and large a byproduct of volume. So the obvious question is, well, how much fluid is this patient getting, or how many blood products in succession? So in the clinical scenario posited at the beginning was, this is 11 units. Well, that's a lot of fluid.
Yep.
Trolley, people will say things like, well, it can happen at any volume, in the first 10 mLs, the first 200 mLs. Volume overload can also happen at any volume, but if you have a normal fluid status going in, you would think that it would be on unit 2, 3, 4, 5. And if you look at risk factors that help to differentiate trolley versus TACO, obviously for the patient that's received more blood products, the risk for transfusion-associated circulatory overload goes up. And that can help to differentiate the two simply by looking at, well, what have you issued and in what time span?
Yep. Okay. So we've kind of talked about you've kind of talked about trying to differentiate by using things like the patient's history and demographic information. You've talked about volume status as well as potentially looking at donor information also. Is there anything? And you mentioned the chest X-ray stuff before. I don't think we need to do that. And I want to hone in on BNP for just a second, Garrett, because I think too many in transfusion medicine, at least historically, before some more recent information came out, people saw this as a magic bullet. Oh, look, BNP. Woo! This will help us for sure to distinguish between TACO and trolley. What are your thoughts on that?
As I said, look, it's better than nothing, right? And so if you were at your wit's end and you simply were struggling to how do you differentiate it, I think ordering brain natriuretic peptide or BNP, or if your hospital has an N-terminal pro BNP, I think it is useful for the diagnosis and the differentiation, but not required. If you look at the sensitivity and specificity of BNP in this regard, people have said, well, it could be anywhere between 80 to 90%. So you're going to miss some of these cases. And as I alluded to before, part of the reason why you're going to miss them is because a lot of patients that are getting blood products already have underlying cardiac disease. So if those cardiac cells, those myocytes are already squeezing out BNP at a basal rate, it's going to be really hard to differentiate it. I would also, again, go back to what is, quote, normal? Well, if you look at normal levels of things like N-terminus BNP, for people that are under age 75, usually it's under 125 picograms per milliliter. I don't think you should get caught up in the numbers. but it's simply to say, hey, if you get older, your rate of normal can be up to 2 or 3 times that of someone who is younger.
Yeah.
So again, if you think about who's at risk for volume overload, it's the same people whose normal range of that lab would already be larger than the younger patient population. So you always have to keep that in mind. And obviously, if you have a history of heart failure in and of itself, you're going to have elevated levels of BNP going in. So serial measurement may also be useful. Or if you get really lucky, someone may have recently ordered a BNP on your patient prior to transfusion. And as a result, then you have a baseline. You can say, well, the BNP was, 120 before transfusion or 2 days before transfusion, and now is, 600. Well, I think you have increased evidence suggesting volume overload. Yeah. But I would also say you don't always have to have that value. And sometimes it can be as simple as just looking at the rate of infusion, right? There are a lot of guidelines that are put forth as what's a healthy or a safe transfusion rate. And, I think sometimes clinicians are very, very busy. Nurses are very, very busy. And so they are trying to get in as much blood as fast as possible because of competing priorities. The patient may need imaging. The patient may have limited vascular access, and they got to get the blood product in so they can start the antimicrobial or so on and so forth. And so you see these blood products oftentimes go in very quick succession, and that can be a tip-off for volume overload. If you say, well, geez, how many units did my blood bank issue before I go to the floor, before I get the phone call? And if they tell you that, well, you've issued 10 units in the last 8 hours, well, that should give you a strong inclination that this patient would be at risk for volume overload, even in the setting of a patient that had normal cardiac function going in.
So what I hear you saying, Garrett, is that while we have a lot of tools at our disposal, in the end, what it comes down to is primarily clinical diagnosis, right?
Absolutely. It is. It's the combination of judgment between the healthcare provider at the bedside and the laboratory professional. Absolutely.
Got it. Yeah, and I think that's really a key for those listening to this podcast to understand. It's that there is no magic bullet here. There is no one laboratory value or one piece of history that automatically distinguishes between these two.
Yeah, you got to build a case, right? Yes. So if it all adds up, then that's what you're going to go with.
And I think it's also important to recognize that when we say this is a clinical diagnosis, that doesn't necessarily mean that the clinicians that you're helping to deal with this are all that familiar with those distinctions. So while it's a clinical diagnosis, transfusion medicine professionals really need to be involved in that discussion, right?
Yeah, you can't sit back and be passive in this regard. And the more active you are with the clinicians and the patient population you serve, the better informed they will be. And a more informed healthcare consumer is simply a better healthcare consumer. And so, yes, make your presence known, not only because you want to demonstrate your knowledge and expertise, but, for example, ABB has standards now that will, go forth in the 30th edition that say you need to let people know what are, infusion rates and help to identify those patients that may be at risk for volume overload prior to transfusion. Awesome. And so if you are an accredited lab, you are now charged with this responsibility. Right.
Yeah, you can't ignore it. That is for sure. Well, so Garrett, that's a great summary. So that's tip number 3. The taco versus trolley is a constant dilemma. And I think I can summarize what we've said by just saying, yes, it's a clinical diagnosis, but it's a clinical diagnosis that the laboratory professionals need to be involved in. So let's move on and do tip number 4. And this one, we've kind of danced around this one a little bit, Garrett, but I'm wondering if you would mind. Tip number 4 is that taco has been defined. And I recognize that there are varying definitions, but would you kind of take us through the at least some of the more common criteria that people use, maybe from the CDC, but maybe I know there are, like as you said, there are competing definitions. But what would you consider criteria currently for diagnosing taco?
So as you're working towards trying to make that diagnosis, or how do you codify it in terms of a hemovigilance perspective, as we alluded to, there are a number of different categorization techniques. obviously for transfusion-associated circulatory overload, there has to be acute respiratory distress. And so without that, you don't have the diagnosis.
Yeah.
That should go without saying. Things that I think are also critically important that the CDC has within their diagnostic categorization are you have to have a positive fluid balance. So you have to be overall net positive. You have more fluid in your body than you're letting out of your body, and thus you're overwhelming your pipe and valve system, and that's what's resulting in the clinical symptoms that are being reported.
Right.
Ancillary things like left heart failure, which can be a new heart murmur, or elevated central venous pressure if you have an art line in place, are critically important if they're there, although not essential.
Right.
Chest X-ray findings, I think, are helpful, but I would say are helpful only in terms of differentiating the obvious cases of trolley versus transfusion-associated circulatory overload. And then obviously being able to rule out or exclude other causes. So as you mentioned, just because they're getting a blood product doesn't mean that they didn't have a pulmonary embolus or that they had a heart attack or something else, hemopneumothorax or pneumothorax may have also happened concurrently, and those obviously need to be ruled out. So those are the important ones for me.
Okay. And Garrett, you mentioned this before, but I wonder if you would mind going over one more time the chest X-ray findings you would expect in circulatory overload.
Yeah, the chest X-ray findings in patients that have circulatory overload are often soft findings, but you may see an increase in the cardiac silhouette. That's just a byproduct of, well, if you've got additional fluid, then the cardiac silhouette is going to expand. So
right.
The tough thing with that is if you only ever have one chest X-ray, then you don't know, is that cardiac silhouette enlarged because of the transfusion or because of the underlying cardiac dysfunction going into it. So if the patients have chronic congestive heart failure, well, that's what you would be expecting to see. Other findings, things like curly B lines, or if you're seeing any type of infiltrate on there, they may be more cephalic in nature, meaning more towards the top of the lungs when compare that to things like trolley, which would by and large have a bilateral pulmonary infiltrate.
Got it. Okay. So that brings us to what I think is, well, if it's not the most important tip, it's really right there. I mean, I think that tip number 5 which is that TACO can be prevented, is really important. And you mentioned the new AABB standard, which is in the 30th edition. I believe it's standard 5.19. 0.7, if I think I have that right, which basically says that transfusion services have to have a policy for responding to requests when patients are identified as being at risk for TACO, and it certainly implies a much bigger responsibility for transfusion services than we used to have in regards to this. I know AABB has made this a big focus, so why don't you, Garrett, take us through, in light of that AABB standard, how do we do things like help our clinicians recognize who's at risk and help them set up infusion rate orders and things like that?
Yeah, absolutely. You're spot on. It's in the 30th edition, it's standard 5.19.7. And this is, I think, is a great standard and a positive step forward to get the people out of the lab and more involved with clinical decision making. One of the obvious things is, how do we identify people at risk? Well, you got to look back at the literature. And as we've talked about, who's at risk would be patients that have underlying cardiac or renal related disease, people at the extremities of life. So again, over 60, under 3 years of age. So how do we do this? We need to provide additional guidance in terms of suggested infusion rates. For adults, most patients, we're thinking anywhere between 150 to 300 milliliters an hour for red cells, 200 to 300 for FFP, 200 to 300 for platelets, and cryo and granulocytes, which is very uncommonly transfused, at least at my institution, typically a little bit faster for cryo and potentially a little bit slower given the riskier nature of granulocyte transfusion. Pediatric transfusions should always be weight-based, particularly for patients that are little itty-bitties like preemies.
Yeah.
But I would say anyone under 40 kilograms, this should apply to as well. Red cells should be going in anywhere between 2 and 5 mils per kg per hour. FFP a little bit faster, 60 to 120 milliliters an hour. Platelets, again, 60 to 120 milliliters an hour. And granulocytes, again, pretty rare, but going in at around 65 to 100 milliliters an hour. So if you know that if that's the background, then you have to say, well, what do we do for these patients that are at risk? And the answer is really simple in terms of prevention. It's to slow it down.
Right.
For example, at Vanderbilt, my home institution, the maximum time that a blood product can be administered to a patient from the time it's spiked to the time the unit is completed is 4 hours. Mm-hmm. So you've got a tremendous amount of time available to you to make sure that the blood product has gone in. And we really set these limits. It's somewhat arbitrary, but as you can imagine, blood products are collected in a closed and sterile fashion. So the moment you spike the unit, you are introducing or potentially introducing microorganisms into the bag and ultimately into the patient. So you got to get it in, within a certain amount of time, but you got a tremendous amount of leeway there. Yeah. But I would say you can also build upon these infusion rates to help meet that standard. And one of the things that you can do is to develop policies, first and foremost, to be doing evidence-based transfusions. This is probably really obvious to the audience listening to the podcast, but you got to take what is out there, both ABB guidelines and results of published randomized controlled trials. And the old adage of, more is better, start giving them blood at, hemoglobin of 10 grams per deciliter and give them, always give them 2 units at a time type of thing. We have moved well beyond that.
Yep.
Nowadays, we really, in the patients, in the absence of known cardiac disease, we're waiting till their hemoglobin naters down closer to 7 grams per deciliter. If you have a history of cardiac disease or vasospasm, you may consider transfusing a little bit higher, 8 or 9, depending on your patient population. But that's the most important thing if you're going to try and limit people from being at risk of volume overload is don't give them too much blood if they don't need it. Time and time again, restrictive transfusion strategies have proven to be either equivalent or in many situations superior to a liberal transfusion strategy. Mm-hmm. So you've got suggested infusion rates, which you can back down on for patients at risk for transfusion if you know those risk factors going into it. You have evidence-based guidelines, which should potentially limit those transfusions, which would be medically unnecessary. And then building in order sets, I think, will also help to enable your patient population from suffering this increased morbidity and mortality risk. So what's an order set? I think that's something that you and I should touch on. Yeah. Order sets are exactly what we've been talking about, which is to make sure that one product goes to a patient at a time. And this is obviously for a non-exsanguinating patient. Right. That will afford the clinical team the opportunity to administer the product and then assess the patient thereafter, trying to make a determination, does this patient even need another transfusion? Additionally, if you look at some of the Cochrane database reviews, people have suggested that if you know this patient's at risk for volume overload, that you may consider concurrent use of a diuretic, most commonly loop diuretics like furosemide, although we don't know what that dose should be, nor do we know the exact timing. Some people have suggested giving it before the transfusion. Other people have suggested giving it during the transfusion, and obviously other people have suggested giving it at the end. So you've got a lot of potential options available to you to try and reduce the risk, whether it's through an order system, through enhanced education and making sure people are aware of the infusion rates, as well as making sure people are aware of the options of medications. But I would also say there's one other option that we in the blood bank can do to help people, and that's product modification. I know that people may groan at this, but if you know that there's a patient that is at risk, you may consider product modification, which may mean that you're going to split the unit. Therefore, instead of giving 350 ml unit red cell out the door, you may give them 150 mLs, and then limiting the donor exposure, you've split that unit, you've sterile docked it, and therefore you give the second half of the unit after they've successfully completed the transfusion. This obviously is, time dependent if the clinical team is willing to wait for it, or just simply looking at the biologic variability of the products you have. So again, going back to platelets, you may have a jumbo bag and you may have a smaller bag, or you may ultimately spin it down and volume reduce the platelets in an effort to avoid volume overloading your patient population. So there are things that can be done from an IT perspective, there are things that can be done from an educational perspective, and there are things that can be done from a blood product modification, all of which will help to reduce the potential burden of volume overload.
So that's an awesome summary. Let's circle back for just a second to our original case where we started talking about, just to remind everyone, the 57-year-old guy who got blasted with 11 units of plasma. Well, just looking at that specific situation, are there any alternatives? Is there anything else these clinicians could have given rather than 11 units of plasma that might have saved this guy a taco?
Yeah, absolutely. Both in the U.S. and outside the U.S., there are alternatives, particularly for things like warfarin or Coumadin reversal, and that would be prothrombin complex concentrates. Traditionally, a 4-factor concentrate would be ideal in this scenario to give back those vitamin K dependent factors. When you compare PCCs versus plasma, it's a no-brainer. PCCs are simply a much smaller volume. So in the patients that have prolonged INRs and you want to try and reverse that rapidly because there's a clinical concern for bleeding or there may be ongoing bleeding at the time, if volume is an issue because they have cardiac or renal disease, spend the money and give them the 4-factor concentrate, because the alternative of putting them in the ICU because you volume overloaded them, and now they require intubation, mechanical ventilation, and the potential risk for death, it's a no-brainer. And going with the alternative product here is critically important.
Absolutely. And I think sometimes we can get short-sighted about this, and we look at the cost of the 4-factor PCC, which in the United States, there's only one approved formulation. There's more elsewhere, but we look at the cost and we go, oh, wow, that's way more expensive than plasma. But how expensive, as you said, is a stay in the ICU? How much value would you put on someone having a reaction like taco, which has a very well-known mortality potential? So I think the risk, well, it's, from my perspective, it cancels out.
Absolutely. And I think sometimes this is lost for laboratory professionals because not every blood bank keeps factor concentrates or issues factor concentrates. And so sometimes you don't see this in the note or the evaluation, in part because blood bank professionals may not have that in their armamentarium. But rest assured, somewhere in your hospital or healthcare network, 4-factor PCCs are available. And this, in these scenarios like the case discussed, this would be a great alternative to giving them 11 units of FFP, which is just enormous in terms of volume.
Well, and just a side note, since I actually wrote the case, I was yelling at myself saying, well, where's the vitamin K in all this too, right?
Yeah, absolutely.
Okay. So Garrett, we are pretty much out of time, but I wanted to just take everyone quickly through our 5 essential tips about taco. And you've done a great job of filling us in on the details here. So tip number 1, taco is one of several respiratory related transfusion reactions. And we discussed not only taco, but also trally and transfusion associated dyspnea and other not necessarily specific respiratory type transfusion reactions. We talked about how taco is wildly underdiagnosed. That's tip number 2, including data from other countries showing just how often it occurs, much more often than we see in passive hemovigilance systems. Absolutely. Number 3 is that taco versus trally is a constant dilemma, and you gave us some great information on trying to distinguish the two as best we can with the underlying understanding that in the end, it is a clinical diagnosis and a clinical distinction. Tip number 4 is that taco has been defined, and you took us through some criteria, including the CDC criteria in the National Healthcare Safety Network for taco. And then the last, we just finished the fact that taco can be prevented, and you gave us some really practical steps and things to look at to try and keep this from occurring. So, Garrett, awesome job. These have been really, I think, very important for people to understand, and I hope that we've given people a little bit better context for how serious this is and how seriously they should take it. Do you have any closing thoughts before I let you go?
No, I would just say thank you, and I want to extend a personal thank you to you, Joe. You've done an amazing job with the BB Guy website, not just with the podcast, the videos, the notes, the questions. I think the entire transfusion community owes you a massive thank you. So on behalf of the transfusion community, the patients that are receiving blood products and the healthcare providers that are administrating them, thank you for keeping this project up and going. Thank you for doing this not just in the last 5 years, 10 years, 15 years, but a whole career dedicated to increasing education and outreach. You've done an amazing job. Keep it up.
You're very kind. I appreciate that very much, Garrett. Thank you so much for being here, and thank you so much for being a guest on my podcast.
Thanks so much.
Hey everyone, this is Joe with a couple of closing thoughts. I hope that you enjoyed that conversation with Dr. Garrett Booth. I have to tell you, he is someone who is a person after my own heart in many ways, in that he is so passionate and enthusiastic about transfusion medicine. I know that you heard that coming through. I really enjoyed talking to him, and again, I'm sure that you learned from that. I really just want to leave you with just this really important thought. Even though transfusion-associated circulatory overload goes by the silly acronym TACO, which I'm on record as saying I'm not a big fan of, I really think that this entity gets disrespected a lot. And in fact, I think that, as we mentioned in this podcast, that clinicians and blood bankers do not take it seriously enough. It is a big deal. And I hope that of everything that you heard today, I hope that you take this away, that TACO is important. It's important to make the diagnosis. It's important to prevent it as much as possible, and to, above all else, take it seriously. It is a really, really big problem. And as I said, I think it's vastly underappreciated. So as we close out episode 21, I will once again thank my guest, Dr. Garrett Booth, and thank you most of all for listening, for your feedback and comments. Please don't hesitate to give feedback on the Blood Bank Guy website, on iTunes, or any place you feel like talking to me. I'm more than happy to hear it. Thanks very much. And as always, as you go through your day, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.